Good morning, everyone. I want to welcome you all for joining us for today's meeting, where we'll be evaluating the effectiveness and value of tolebrutinib for secondary progressive multiple sclerosis, or SPMS. The data will be presented today from the Institute for Clinical and Economic Review, better known as ICER, and it will be presented to the California Technology Assessment Forum, or CTAF, where an independent panel will be looking at the evidence and then voting on some key questions. My name is Ralph Brindis, and I have the privilege of chairing this meeting. And at this time, I'm going to ask our individual CTAF members to introduce themselves and declare any potential conflicts of interest. And I would like each of our members to also tell us a little bit about what their day job is and if there are any new conflicts of interest to disclose. With that in mind, I'm going to introduce each of our panel members, first being Robert Collier. Bob?
Oh, I love going first. I'm Bob Collier. Been a professional patient advocate, or want of a better word, for a little over 30 years now in the world of medical research, and I have no new conflict of interest at all.
Okay. Paul Heidenreich, Dr. Heidenreich.
Hello, Paul Heidenreich. I'm a professor of medicine, cardiologist, and vice chair for quality in the Department of Medicine at Stanford University. I have no conflicts.
Dr. Jeffrey Hawk.
Good morning, everyone. My name's Jeffrey Hotch. I'm a professor of health economics at the University of California at Davis. I have no conflicts of interest.
Dr. Jeff Klingman. Jeff?
Oh, sorry. Jeff Klingman. I'm a neurologist with the Permanente Medical Group in Northern California. No conflicts.
Thanks, Jeff. Dr. Annetta Langer-Gould.
Hi, I'm a MS specialist at Southern California Kaiser, and I am the site PI for the frexalimab trial that's also sponsored by Sanofi.
Dr. Sei Lee.
Hello, I'm a professor of medicine at the University of California, San Francisco. I am a geriatrician and palliative medicine doctor, and also conduct research on individualizing prevention in older adults.
Dr. Joy Melnico.
Hello. Hi, I'm just getting my audio going. Excuse me. Dr. Joy Melnico. I'm a family physician and professor of family and community medicine, professor emeritus at the University of California, Davis. I have no conflicts.
Dr. Lisa Murphy.
Hi, I'm a professor of medicine at UCSF and an endocrinologist. I have no conflicts related to this meeting, but in the spirit of full conflict disclosure, I get royalties for a patent on a diabetes diagnostic and also receive travel and speaking fees for Big Island Physician Group.
Dr. Catherine Phillips.
Yes, good morning. I'm Catherine Phillips, professor of health economics, University of California, San Francisco, and no new conflicts.
Dr. Rita Redberg.
Hi, Rita Redberg. UCSF is well represented. I'm a professor of medicine at UCSF and core faculty in the Institute for Health Policy Studies. And my research is on how to promote high-value care. I have no conflicts of interest.
Thanks, Rita. Joanna Smith.
Hi, good morning, everyone. I'm Joanna Smith. I'm a licensed clinical social worker in Oakland, California, with a specialty now in end-of-life care options, and I have no conflicts of interest.
Thanks, Joanna. Tony Sowery.
Yeah, good morning, everyone. I am a volunteer counselor for Medicare for one of the SHPTers in Northern California, and I have no conflicts of interest.
And again, I'm Ralph Brindis. I'm a cardiologist by training, clinical professor of medicine at UCSF, and I have no new conflicts of interest to disclose. This time, I'd like to introduce our panel, some of our guests today, and also to have them describe themselves and any new conflicts of interest. First, Kathy Costello.
Morning, everyone. Currently, I am the interim CEO for the Consortium of Multiple Sclerosis Centers and the International Organization of MS Nurses. I also serve as strategy lead for another nonprofit, Can Do Multiple Sclerosis. I'm also the president of the Multiple Sclerosis Coalition and am adjunct faculty at Johns Hopkins. I have no additional conflicts to report. Thank you.
Kathy, thank you so much for being with us today. Nancy Garcia.
Hi, I'm a retired board certified chaplain and secondary progressive MS patient, and I have no conflicts to disclose.
And Nancy, again, thank you so much for being with us today.
No problem.
Next slide, please. Dr. Robert Bermel.
Sure, my name's Robert Bermel. I'm a neurologist and director of the Mellon Center for Multiple Sclerosis at Cleveland Clinic in Cleveland, Ohio. Really happy to be here today. I do want to disclose that I have served as a consultant as well as conducted clinical trials with MS companies, including Sanofi, Roche, Novartis, and TG Therapeutics. And I serve as a medical director for a nonprofit copay assistance foundation called the Assistance Fund that gets a portion of its funding from pharma companies. Thank you.
Thank you so much for being here today. Dr. Ellen Mowry.
Hi, I'm Ellen Mowry. I'm a professor of neurology and epidemiology at the Johns Hopkins University, where I work with people with multiple sclerosis. The only other conflict I have is that I do editorial duties for Up to Date.
Thanks again for being with us today. And I'd also like to request any other speakers during our policy roundtable or individuals making public comments, they also should announce their financial relationships with industry or any potential influences of judgment when they speak. We will also present this information publicly on slides. At this time, I have the pleasure of introducing Sarah Iman, who's the president and CEO of ICER. Sarah?
Ralph, thank you so much. Let me also add my thanks to our patient experts and our clinical experts for being here today. I'll do a few opening remarks before turning it over to the research team to walk us through the evidence on the effectiveness and value of this new therapy for SPMS. But first, a few introductions. I'm Sarah Iman. I'm ICER's president and CEO. After I speak, you'll hear from Dr. Grace Lynn. She's the evidence author for this report. She's a medical director for health technology assessment here at ICER and also a physician researcher at UCSF. Felucio Agbula, our senior vice president of research, served as the senior management team lead today for this review. So you'll hear from her today as well. And Dr. Brett McQueen, an associate professor at the University of Colorado, led the economic modeling. And so we'll hear from Brett in a little bit. Next slide, please. Whenever we kick off a meeting, and our meetings cover a lot of different topics. We've talked about MS before as an organization. We want to remind ourselves why we're here. These are a few quotes from the patients that we heard from when we started our review and throughout our review today, because we want to always think about what patients are trying to achieve from the therapies offered for their condition. But we need to understand what it's like to live with the condition in order to know how to judge the effectiveness and value of new therapies. One patient told us it's been a long journey. I started with a cane, which became a walker, which became a rollator, which was replaced by a small electrical foldable wheelchair. I mostly talk to my computer. I don't attempt to type anymore. Another told us, it's very hard not to be in a completely depressed place because I just feel like unless someone comes through with something truly novel, I've done really all the drugs that are out there. And finally, I think balance is a big one for me and fatigue. I have an identical twin sister, So it's a very good way of seeing how much my life is impacted. You know, she does a lot more than I do. You try to do a thing and you just don't have the wherewithal. We appreciate all of the patients who spoke to us throughout this review so that we could be grounded in their experience as we think about the effectiveness and value of this potential new therapy. Next slide. The other thing that we do is that we want to talk about things right around the time of FDA approval, because we think about what happens the day these treatments might receive FDA approval. We think about the celebration that might be felt by a community that's waiting for a novel therapy. We think about the decisions that policymakers will need to make about price and access. And we think about the comparative clinical effectiveness. What are the risks? What are the benefits? How does this fit into the treatment paradigm for this particular condition? And we do not shy away from a conversation about costs. Costs to patients, costs to the healthcare system, and costs to those of us paying into a system that pays for healthcare, right? Through our healthcare premiums. And we'll always spend time in every ICER review with the humility to know that we don't have all of the answers. So what are the questions that we need to be continuing to ask so that we're centering patient experience in conversations about price and access so that we can have future research to answer those questions? Next slide. And we don't shy away from costs because we're familiar with these stories. We're familiar with stories of families who are faced with big bills to afford their health insurance. We have families who have twins that were born premature and went into debt trying to pay for their costs when they were in the neonatal intensive care unit. We have stories of people who needed to go to the doctor and were turned away because they had an outstanding balance and then ended up in the emergency room, a place for more expensive care because they couldn't be seen by their primary care doctor. And we know that companies and employers that offer insurance are faced with higher and higher costs for these premiums to offer us all access to healthcare at the expense of other things like wages and investing in the development of new manufacturing plants or whatever it might be for their own business. And so we know that there's a real impact on real people because we are spending more and more on healthcare. Next slide. So what we really want to focus on is not only the patients with secondary progressive MS who are probably anxiously awaiting a decision from the FDA on this new therapy that may help them, but we will remember all of the other people in the healthcare system who are struggling with costs, who are struggling with access, because we have a vision that we can have affordable access for everyone. So that means we can talk about the evidence for this new therapy and what a fair price should be so that we do not harm other people in our healthcare system through higher and higher insurance costs. This is the underpinning of the sort of philosophical bent of ICER, is that there is a price that matches the benefit patients receive. And when we pay that price, we're able to offer more affordable health insurance to the entire community. Next slide. So you've already got a little bit of the vibe of ICER. That's the Institute for Clinical and Economic Review, the group that I have the deep honor of running. We have 3 independent appraisal committees. They are separate from us. They are experts in evidence-based medicine, cost effectiveness, comparative value, patient and consumer engagement. And today we are thrilled that members of the California Technology Assessment Forum are here for this public deliberation. Next slide. We want to be very transparent about who we are and where we get our money. And so this represents the sources of funding that we have. Any money that we get from health plans, provider groups, or manufacturers supports a policy summit that tries to tackle a big issue facing us all. Our last one was on how to pay for GLP-1s for obesity. The one before that was how to pay for gene therapies. And so you sense a theme here. All of the research that ICER conducts, however, is funded only by nonprofit philanthropy and individual philanthropists. So you see that represented in this chart. I also want to highlight that if you're interested in how we manage our own potential influences on judgment and conflicts of interest, that link is available so you can see the restrictions that we have as employees and the restrictions that our voting members have in order to participate in our meetings so that we can try to manage the conflicts of interest as best we can. Next slide. A little bit about the report and what we have in front of us today. The report is available at ICER.org for those listening along at home and want to have that handy. You can find that under the assessments section of our website. But we spent about 8 months getting to this point. And we started by talking to patients and clinical experts in the manufacturer about which research questions we should be asking about the potential new therapy for SPMS. We went through an evidence synthesis, a systematic literature review. We developed an economic model, and we are very grateful for the expert review that we received, both from the clinical and the patient community. Of note, none of our expert reviewers, our patient experts today, our clinical experts today should be assumed to endorse any part of the ICER review. That is solely the work of ICER and our academic collaborators. Our draft report went up for comment. We have all of the response to comments also available on our website, so you can see how we thought about the feedback that we received from the community. The report was then revised and is the basis of the conversation today. It's got a background section. You can hear more about the insights we gained from talking to patients and their families. You get a deep dive in the clinical evidence and the cost effectiveness, and also a section talking about other benefits and special ethical priorities. Next slide. This is just a visual representation of how we think about value, because all of these dimensions are going to come up today. And the parts in green represent things that are typically a little easier to measure from clinical trial data. If it's a drug that's been on the market for a while, it might be real-world evidence. We can know if the drug is helping you live longer, if it's a life-limiting condition. We can tell if the drug is helping you feel better in terms of the side effects or the symptoms of the disease. And we can also measure how much it costs to introduce the therapy and how much we might save. Think an avoided future hospitalization, for an example. All of that forms the basis of our comparative value analysis. But we always acknowledge there are critically important aspects of value that sometimes are harder to measure, and we put them into these buckets: special social ethical priorities and benefits beyond health, so that we have a form to elevate those considerations and those aspects of value. And this panel will even vote on how they view some of these special ethical priorities and benefits beyond health, so that ultimately policymakers have the best view of the comparative value of this new therapy when they are then charged with making decisions about price and access. Next slide. You've made it through the introduction. Congratulations. We'll be handing it over to Dr. Grace Lin in just a moment, who will talk to us about the comparative clinical effectiveness review. And then Brett will talk us through the economic model. We'll take some public comments and have a conversation. After breaking for lunch, the CTAF will then go through the voting questions, thinking about the comparative clinical effectiveness of this new therapy and voting on those other benefits and special ethical priorities. After a break, you'll have me again. I'll be back to moderate a policy roundtable where we reflect on those votes and what we know about the evidence and what does that mean for evidence-based policymaking, for future research needs, and for guiding fair access for patients. We'll close with some reflections for CTAF, and we will be wrapping up around 3 p.m. Pacific time today. Next slide. With that, it's my esteemed pleasure to introduce Dr. Grace Lin, who will talk us through the comparative clinical effectiveness. Thank you, Grace.
Thank you, Sarah, for that introduction. Hello, everyone. As Sarah said, I will be going through the clinical evidence for tolobrutinib. Next slide, please. I was assisted on this review by my colleagues from ICER's outstanding research team, Shahryar Mohammed Fahim and Finn Raymond. I will note that financial support is provided to UCSF through UCSF to me from ICER, but otherwise there are no conflicts to disclose. Next slide, please. So as we know, Multiple sclerosis is an inflammatory disease that damages the myelin sheath, leading to progressive deterioration of axons. It's one of the most common neurological conditions affecting nearly 1 million Americans. Women tend to be affected more than men, and this tends to be a disease of younger people, with most of the people affected between the ages of 45 and 65. There are some racial and ethnic disparities that we can note. Black persons in the US have a higher incidence of disease, more rapid disease progression, and greater disability. The onset of disease also appears to be earlier in Hispanic persons who are born in the United States. Most people with MS start out with a relapsing remitting course of MS, or what we call RRMS. Then over the next 3 to 4 decades progress to a form called secondary progressive MS, or SPMS. Next slide, please. So I will say that the multiple sclerosis is a disease that progresses along a continuum. And so I'm going to talk a little bit about the categories, but I'll just note that the transitions from one category to another aren't always clear, and that will, I think, come out in the discussion today. So as I mentioned, RMS, most people with MS start in the RMS category. This is where the predominant characteristic is clinical relapses, and then people, get better and then have another relapse. Eventually, many people progress to what we call SPMS, which is where the predominant characteristic is progression of disability independent of relapses. And there are two forms of SPMS. You can have active SPMS, where you have clinical relapses or MRI activity, or you can have non-active SPMS, where there are no documented clinical relapses and no documented MRI activity. Next. So you'll see that there's also a split in terms of having relapses and not having relapses. So here in the red box, we have people who are having relapses, either clinical relapses only, or clinical relapses with MRI activity. And those we call relapsing forms of SPMS. Next. Next. And now on this right side in this box, we have people with MRI activity only. So these are people with active disease, but not clinical relapses, or no MRI activity and no relapse. And these are what we call non-relapsing forms of SPMS. Next slide, please. MS produces a lot of symptoms. There are general symptoms like fatigue and pain, neurological symptoms like numbness, weakness, cognitive mood changes, poor balance and coordination, muscular symptoms like muscle cramps. Also, people can have difficulty swallowing, especially as they progress to later stages of the disease, and they can have bowel and bladder incontinence, which is a prominent symptom, especially again later on in the disease. Next slide, please. So as you can imagine, with all these symptoms, MS has a large impact on physical health, mental health, and because, as I mentioned, the disease starts in younger people, there's an impact on work and educational productivity, family planning, and leisure activities. We heard from people living with MS that both initial diagnosis of MS and the transition to SPMS may be delayed for a number of reasons. We also heard that some of the symptoms are not adequately treated by current disease-modifying therapies, or DMTs. We heard that access to specialist care and coordination of care can be very difficult given the shortage of neurologists and MS specialists. As you can imagine, as people accumulate disability, there's a very high caregiver burden. And finally, we heard from older patients living with MS that they were afraid they may not be treated as aggressively as some of the younger patients with disease-modifying therapies. Next slide, please. The MS Coalition also did a survey of MS patients. And from that survey, we learned that persons living with SPMS reported substantial mobility impairment. We also learned that slowing of progression is an important goal, but when we talk to patients in focus groups, we also learned that they would like to see drugs aimed at clinical improvement and remyelination, not just slowing progression. substantial number of persons living with MS reported delays in treatment due to financial barriers. It's important to note that a substantial number of people receive financial assistance in order to pay for their medication. Next slide, please. So the standard of care and management for non-relapsing SPMS. Again, we are going to talk about non-relapsing forms and relapsing forms. So for active SPMS, and this is the blue box, people who are still having relapses, the standard of care is a disease-modifying therapy plus supportive care. Next. But when we talk about when we talk about non-active SPMS, there are no current drug therapies that are FDA approved for this population. So their standard of care is supportive care. Next slide, please. So today we're going to assess the clinical effectiveness of tolebrutinib compared with usual care in persons living with non-relapsing forms of SPMS. Next slide, please. So tolebrutinib is a Bruton's tyrosine kinase inhibitor. This inhibits the BTK enzyme, which affects function of B cells, which are immune cells that play a significant role, are thought to play a significant role in the inflammation and damage associated with MS. Tolebrutinib is a BTKI that penetrates the central nervous system, and that's why it's being looked at for MS. It's a once daily oral medication with a 60 milligram dose. It's been studied in relapsing forms of MS in the clinical trials called Gemini, non-relapsing forms of MS in a clinical trial called Hercules, and it's being studied separately for PPMS in a clinical trial called Perseus. So today we're going to focus on Hercules and the non-relapsing forms of MS. A new drug application was filed by the manufacturer for non-relapsing forms of MS with a decision expected by September of this year. Next slide, please. So let's get into the clinical evidence. So as I mentioned, the pivotal trial is called Hercules. It was a phase 3 randomized double-blind placebo-controlled study. Participants had to have a diagnosis of non-relapsing SPMS. They had needed a expanded disability scale score of 3 to 6.5, and no documented clinical relapse in the last 24 months. In addition to the no clinical relapses, participants also had to have documented disability progression in the last 12 months. So when we looked at trial participants, there were over 1,100 trial participants. They had a mean age of 49 years, a mean EDSS score of 5.5, around 5.5. This was a predominantly female, predominantly white clinical trial population. They were 7.5 to 8 years from SPMS diagnosis and their last clinical relapse. And about 13% of them had what would be classified as active SPMS, where they showed some MRI disease activity. Next slide, please. The primary outcome in this trial was time to 6-month confirmed disability progression, or the period it takes for a patient to experience and maintain a specific increase in their EDSS score over a 6-month period. There were also 6 hierarchical secondary outcomes. And this is important to note because hierarchical testing in a clinical trial follows a predetermined order. And this approach helps manage multiple testing so that we avoid false positives and ensures that the most important secondary endpoints are prioritized. So here, when they did the statistical testing, they did it in the order listed on the slide: time to 3-month CDP, number of new or enlarging T2 lesions, time to sustained worsening of 9-hole peg test, time to sustained worsening of 25-foot walk test, time to 6-month confirmed disability improvement, and percentage change in brain volume. And that will become important in the next few slides. Next slide, please. So here we have the graphic of the primary endpoint, or time to 6-month CDP. So the analysis, so even though this graph goes out to 45 months, the primary analysis was done at 24 months, so sort of in the center of this slide. So at 24 months, the hazard ratio for time to 6 months CDP was 0.69, and this was statistically significant. So what this translates into is about a 30% slowing in the time to a 6-month confirmed disability progression. So basically, you're delaying time to progression. You'll notice that, as I said, the graph is at 45 months, but and participants were to be followed in the trial up to 48 months, but very few people have been followed to that period of time. So all the outcomes I'm going to talk about are at 24 months. Next slide, please. Here we have started to look at the secondary outcomes. So that first line you'll see is the proportion of patients achieving 6-month CDP. The second, then we have proportion of patients achieving a 20% worsening of 9-hole peg test. Now, the 9-hole peg test is a measure of upper extremity function. And basically the time, they measure the time it takes for you to do this dexterity exercise. You can see here that this there was really no difference between the tolebrutinib group and the placebo group, with a hazard ratio of 0.97, and this was not statistically significant. And because this was not statistically significant, the following secondary outcomes were not tested for statistical significance. So you'll notice that there are numerical differences in the proportion of patients achieving the 20% worsening on time 25-foot walk and confirmed disability improvement, but those were not tested for statistical significance because they fell underneath the 9-hole peg score in the hierarchy. Next slide, please. The trial also looked at MRI outcomes. They looked at the annualized new or enlarging T2 lesions, and there was a statistically significant difference with the tolebrutinib group having fewer new or enlarging T2 lesions. They also looked at change in brain volume loss. You can see here that there was numerically, there was very little difference in the tolebrutinib group versus the placebo group. And again, this was not tested for statistical significance because it was low in the hierarchy. Next slide, please. So we talked about the clinical outcomes for tolebrutinib. Now we'll talk a bit about the harms. There were fairly high rates of discontinuation in the trial. Around a quarter of the patients discontinued tolebrutinib. 4% in the tolebrutinib group discontinued, had the discontinuations were related to adverse events versus 3% in the placebo group. For serious adverse events, 15% of participants in the tolebrutinib group experienced a serious adverse event, and versus 10% in the placebo group. It's important to note that there were 2 deaths in the tolebrutinib group, one of which was deemed related to the drug, and I'll explain more about that in a subsequent slide. And there was 1 death in the placebo group. The most common adverse events were nasopharyngitis, falls, headaches, and infections like COVID-19, respiratory infections, and urinary infections. Next slide, please. So one of the main toxicities of BTKI drugs like tolebrutinib is liver toxicity. So there was a special emphasis on looking at liver toxicity in the trial. And liver toxicity was defined as elevation of liver function tests above 3 times the upper limit of normal. So in the trial, 4% of participants experienced LFT elevation more than 3 times upper limit of normal. There were 4 total cases, or 0.5%, of severe liver toxicity where the liver function test was 20 times of the upper limit of normal, including 1 person who required a liver transplant and died post-transplant from complications of the liver transplant. After that death, the monitoring of liver function tests in the trial changed to the schedule that you can see on the slide. So participants starting the drug were required to have weekly monitoring of their liver function tests from weeks 2 to 12, monthly monitoring of their liver function tests from months 3 to 12, and then quarterly until study completion. After the protocol changed, there was one case reported of a severe liver toxicity. Next slide, please. So there are some controversies and uncertainties from the data that I presented. As I explained from previous slides, there were mixed results on secondary endpoints. For example, there was no difference in brain volume loss, which is thought to be a marker of progression in MS. There has not been any report on data on patient-important outcomes, such as health-related quality of life or cognitive function. So we don't have those data for this drug. Only a few patients achieved disability improvement in the trial. We note that because of the intense monitoring of liver function tests, there may have been some potential unblinding as patients figured out which groups that they were in. This is a new mechanism of action, and so there's no long-term safety data, particularly with the LFT abnormalities that can occur. And finally, there's no data on subgroups. Remember, I said that there were about 13% of patients who were active SPMS and the rest non-active SPMS, and we don't have any data on how the drug performed in the two different groups. Next slide, please. We can talk a little bit about benefits beyond health and special ethical priorities. We heard from our clinical experts and from our patient experts that there's a substantial unmet need for SPMS. There are no treatments that are currently FDA approved for non-active SPMS. We heard that Black Americans living with MS have a higher incidence of disease, more rapid progression, and greater disability. We heard that slowing of progression may decrease caregiver burden. And we heard that oral administration may improve access in some cases because many of the other disease-modifying therapies are infusions, which require access to an infusion center. Next slide, please. As always, we appreciate the public comments that we received on our report. We wanted to note that we received a comment that elevation in liver function tests were mitigated by implementation of a more intensive monitoring program. As I mentioned earlier, though, this program might be very difficult to simulate in real world practice with the weekly monitoring that was required for the first 3 months of being on the drug in a population that has mobility challenges at baseline. Next slide, please. So in summary, tolobrutinib slows progression of disability in persons living with SPMS. There's some mixed data on secondary outcomes, but the treatment could possibly lead to disability improvement in a small number of people. There remains a risk of severe hepatotoxicity, and there is intense monitoring, but again, that might not be that practical in the real world. But as I mentioned, there's a lack of current treatment options for non-relapsing forms of SPMS, so tolobrutinib could help fill an important gap in care. Next slide, please. So taken together, between the clinical trial results, the harms, and the special ethical priorities and benefits beyond health, when we thought about tolobrutinib versus best supportive care for this population of non-relapsing SPMS, our evidence rating is promising but inconclusive. And what this takes into account is that we have moderate certainty that there is a small or even a substantial net health benefit. But because of the concerns of liver toxicity, we also include in there a chance that there's a likelihood of a net negative health benefit. All right. Thank you very much for your attention, and I'm happy to take questions.
Well, thank you very much, Grace, for a very lucid and concise presentation on the effectiveness of tolobrutinib for secondary progressive multiple sclerosis. At this time, I'd like to open it up for our panel members for some questions or comments for Grace or our medical experts. I saw Rita. I heard your hand was up first.
Thanks, Ralph, and thanks, Grace, for, as always, a great summary. I'm just, and you did go through it in the written report, but I'm still not exactly clear on how one can diagnose non-active SPMS and active SPMS with MRI activity only, and how those distinctions are made and what that means sort of clinically for a patient. If you have a non-active disease, does that mean you're stable for a long time at a certain level? And I have one more question after that. Thanks.
Thanks, Rita. Yeah, no, this is something that we struggled with as a team, trying to understand the different nuances. I think as I mentioned, I think MS is a continuum of disease, and so these categories are a bit artificial. SPMS is particularly difficult because it's a retrospective diagnosis, right? You have to basically say, oh, you haven't had a relapse in this amount of time. And so I will actually ask our clinical experts, Dr. Mowry and Dr. Bromell, to sort of weigh in on how they apply this in clinical practice.
I'm happy to start. Thank you so much for the great question, and thanks for welcoming me to this discussion today. Yeah, it's a really great question. And by the way, the ability to distinguish active and inactive MS can be challenging too, because right now it involves both clinical impressions and history, but also monitoring by MRI scans, and the access to routine and frequent monitoring of people with MS is certainly not equitable around the world, and I would argue not even in the United States. But activity in folks with MS means that we're talking about they're developing acute, meaning kind of quick or short-term changes that are induced by the immune system, causing little areas in the nervous system to have demyelination. And this is something we detect either as a silent bit of activity that shows up as a new lesion, or as I like to call them, white spots in the brain that you can detect on MRI or in the optic nerve or spinal cord. And also sometimes those little spots show up in really clinically relevant parts of the nervous system, such as the spinal cord typically, or the optic nerve. And if that happens, you might detect symptoms associated with it. Although I would say in people with more disability at baseline, like the population that was included here, it can be tricky to figure out if they're having relapses, because they have a background of neurologic symptoms and findings on their exam that can make it hard to confirm. There are some new biomarkers that are in development and are clinically orderable that tell us if there's been some recent neuroaxonal injury, although it's not specific to MS. Certain other conditions can elevate those biomarkers as well. But how we monitor people in our clinic is people who have active MS, they have relapses or lesions, typically are recommended for these immune modulating therapies that we already have approved. And we monitor if the medications are working by whether they take away active disease, lesions, and new relapses.
Thanks, Ellen. Robert, do you have any additional quick points for us?
Yeah, just number one, it's awesome to team up with Dr. Mowry on this. Thanks, Ellen. Totally agree with all of that. I would just additionally add that this is tied to an unmet need, and the concept of non-active secondary progressive MS, I guess, comes when we see patients who are getting continually worse. So they're not stable per se. They're stable by the elements that we often monitor, like MRI scan, which is brought up, or monitoring for relapses. We can't see evidence of disease activity in terms of acute inflammation, but yet people are getting continually worse. If we go back to the clinical trials that have been done in progressive MS in the past, people who have that disease activity superimposed on progressive worsening tend to benefit from the existing therapies. So the existing immune therapies for MS benefit people proportionate to the amount of those new lesions or the new activity that they have. And so that unmet need that I think the secondary progressive MS, the non-active secondary progressive MS nomenclature is trying to get to, is this concept that's called progression independent of relapse activity, or the patient need for the patients who are getting worse despite, in the absence of acute inflammation, basically. And I think that that's what the intent is. It's not entirely academic, even though these, nomenclature evolutions over time just get like really difficult even for MS experts to keep up with. I think it really is tied to, I think, an unmet patient need.
Thank you
Oh,
so much.
thanks. Ralph, can I just finish the other question and comment? I know that.
Go for it.
Thanks. Because I asked the question because, I mean, obviously, I think it's important for us to think about treating the patient and their symptoms and treating all of this imaging and biomarkers that are done. And there is, as you know, an interaction, certainly in cardiology, once we image someone and say they have non-significant plaque in their arteries, they come in with many more symptoms, or they think they have many more symptoms because now we've told them about something. And I just worry about that interaction in a disease that it wasn't clear to me when we were treating clinical symptoms and when we were treating, we're looking at the imaging. And related to that, I was concerned on why there were no quality of life indicators and wondering what that EDSS score, which I think was the primary outcome for Hercules, how that relates to quality of life or clinical functioning.
Grace, would you like to answer that?
Yeah, I will. The EDSS Rita is a standardized scale that examines disability. So it's primarily ambulation. It's that's the anchor, so that an EDSS of 1 or 0 is no disability, and then an EDSS of 8 is somebody who's bedbound, basically. And so in this trial, so SPMS patients tend to be on the later end of that and the higher scores. So the mean EDSS here was 5.5, which equates to progressive disability and difficulty with walking. So there is some correlation with quality of life, but it's not a one-to-one correlation. The manufacturer did, we understand they did collect quality of life data in the trial, but they have not reported it in any forum or in any publication. So we don't have that data.
Grace, that was very helpful. I want to make sure our other panelists have a chance to ask questions. Lisa? You're on mute, Lisa.
Sorry, I did. So I have questions in the liver direction, and I think other people want to follow on this current conversation. So I will, if people want to continue on the previous conversation, I'll hold off, and when they're done, I can come back. How's that?
It's for you, Lisa. You're up.
Okay, it's just a quick question for Grace then, and I don't know if this is known. For the patient who did have severe liver toxicity during the monitoring, the more aggressive monitoring, at what phase of the monitoring was that? Was that weekly, or was that in the later phases? And was there no hint earlier with the weekly monitoring that it was 3 times the upper limit of normal? And if people had 3 times over the upper limit of normal, were they withdrawn?
Those are good questions. So all that we know about that patient, that one patient after the monitoring change, was that it occurred within the first 90 days of the drug, because all of the severe toxicity occurred within the first 90 days, but we don't know at what point. We don't have those data. And then I'm sorry, your second question.
When did they withdraw people? So if it went over 3 times the upper limit of normal, were they withdrawn?
So they stopped so if it was over 3 times the upper limit normal, they stopped the drug. They actually instituted more intense monitoring every 2 to 3 days. If the LFTs came down, they could make a decision about whether to restart or not. And then go back into the monitoring. So that was a decision made. So they could continue on in the trial, or they could be discontinued. But that was a decision made at the clinical, by the clinical physicians making those determinations.
Great, thank you.
Great question, Lisa. Joy? You're on mute,
Thank
Joy.
you. Yeah, now I'm off mute now. So this is a question just to put these results in context for those of us who are not neurologists and haven't seen results of other therapies for relapsing remitting MS. To me, when I look at this clinical disability progression difference, I'm not excited about it very much. It doesn't seem very big. It seems, I would say, small on a scale of small to large. And and it's only deterring progression. I mean, the number of people that actually seem to improve was much, much smaller. So how does this compare to other therapies for relapsing and remitting MS? Do we have drugs for that condition that have more substantial benefit?
I think I'll defer to Dr. Mowry or Dr. Bermel to put that in perspective for us.
Sure. So we've evolved quite far in relapsing remitting MS these days and have highly effective disease modifying therapies. I would liken the magnitude of this effect to more similar to our earliest therapies for relapsing remitting disease, the early interferon trials, for instance. I think if you take primary disability progression as a primary outcome measure, it was a small difference small but statistically significant difference in the proportion that had disability progression, for instance, in the interferon beta 1A trial that was driven by disability. I think it was 78% free of disability in one arm in the interferon arm versus 65% free of disability progression in the placebo arm. So since then, relapsing therapies have changed dramatically and our standards have gone way up. But I think this is sort of what the beginning of, in my view, tackling, I think as Grace pointed out, sort of a new mechanism of action and a new category of disease pathology that we haven't really done yet.
Okay. Annetta? Oh, I'm sorry, Grace, do you have an additional comment for us?
Thanks, Dr. Morel. I will say, and I think I mentioned this in the presentation, this drug was tested. There was a trial, there are a couple trials in the relapsing population with tolebrutinib called the Gemini studies, and their primary outcome was relapse rates. And the drug versus teriflunomide, which is another early and not very effective disease modifying therapy, it was no better than teriflunomide in terms of preventing relapses. So this is partly why the focus has been on the SPMS population.
Thank you for that clarification. Annetta?
Yeah, hi. So I am actually just like very concerned that we are not able to see the data in the inactive subgroup, because that's really where the high unmet need is. And I'm troubled by the fact that 13% of the patients in the trial had active SPMS, and the absolute difference in disability progression is only 8%. And then, so it is certainly entirely possible that the entire treatment effect is being driven by the active subgroup for which we have better treatments, and we don't consider that a high unmet need. If you put it in context with Hercules, with the relapsing remitting MS trial, where there was no effect on relapses and actually did a little worse on inflammatory lesion outcomes on their MRI scans, it raises this concern for me for my patients. If they're coming into my office with active SPMS, could I potentially make them worse with this drug? I certainly wouldn't grab this drug first, and I don't see the data to tell me whether or not it works in this inactive group, which of course was what we all want for our patients. The other thing I wanted to say about Rita's comment is SPMS is a very slippery diagnosis. Most general neurologists are not able to accurately assign that diagnosis. This is really something that's done by MS specialists. Access to MS specialists, as I'm sure Kathleen can speak to later, is incredibly low in the United States, particularly among disadvantaged populations. So even like just getting that right subtype assigned and then being able to going from that to access to therapy is not good. And then I think Ellen can speak to the fact that it's also applied differently across countries. So, we have old evidence showing that Americans are much more likely to wait until somebody needs a cane before they'll say they have SPMS. Whereas in Europe, they're much quicker to say they have SPMS, even when they have only only have moderate disability impairment. And then lastly, I just want to point out about the endpoints, right? So EDSS in this trial, half the patients had a cane or worse. And you go from a 6 to a 6.5, which is their definition. 6 is a cane, 6.5 is a walker. How much worse your hands get does not really change that score. It's really ambulation driven. If your bladder function gets a lot worse, that doesn't really change your score either. Cognition gets a lot worse, also doesn't change your score, which is why those other outcome measures matter. Right, so time 25-foot walk is another measure of walking speed. So it would be extremely unusual, and it's certainly reassuring to see that it goes in the same direction as the EDSS. But hand function, there's absolutely no difference. And then all of those are subjective measures. So they also depend on the patient's motivation, how far they had to walk from the parking lot to get into your clinic that day, how hot it was outside, whether they've had a recent urinary tract infection, will all make them look worse. So we do rely on an objective measure, which is this brain atrophy. And so it is very troubling that it had absolutely no effect on brain atrophy. And I'll end with that.
Well, we're drinking from a fire hose, Annetta, from all your comments. I want to let the group know we have maybe about 4 or 5 more minutes. Ellen, did you want to comment on piggyback on some of Annetta's comments? And then we'll go to you, Kathy.
Yeah, I guess I would agree. You were asking Rita about active and non-active, but in this study, I think they enrolled people who were non-relapsing, meaning they hadn't known about any relapses. But certainly we know that a bunch of people at the beginning had active lesions right at that moment. And that only tells you about what's happened in the last 4 weeks or so. I also think it's important to remember when we're considering what patients, might benefit from a treatment. If you look at who was enrolled in this study, like a quarter of the people who had a known prior relapsing MS had never been treated with anything. And then of those who were treated, most of them had been treated with more moderate efficacy therapy. And to have people then still having active disease is just a little bit atypical for how we treat people with MS these days. We normally treat to no active disease. So I don't know that the patient population that was enrolled received kind of the standard of care treatments that we would give today. And I suppose that relates to trying to then understand, well, would the people that we're treating actually benefit from this intervention? There are a lot of subgroup analyses that were pre-planned that we didn't see, particularly stratified around, the presence or absence of new lesions at baseline, though, given the trial results from Gemini, it would be nice to kind of see what those were like adjusted throughout the trial as well. Stratified by baseline disability, which the ICER report anyways suggests that it's the people who had much less disability, and those are probably the people who had more active disease, more new spots, and were probably younger, since that relates as well. And we know that that's a pretty small group because the 25th percentile of EDSS at baseline was 4.8. And so that's a pretty small group of people who are driving that result.
Thanks so much, Ellen. I want to make sure I'm really interested. I'm sure our whole panel is interested in Kathy's perspective, particularly with her roles as president of the Multiple Sclerosis Foundation. Kathy?
Thanks very much. So just a couple of comments, and the first being on the categorizations of MS as relapsing remitting or secondary progressive, active, non-active. It's quite complex, but I honestly believe that people with MS do the best job of all in describing what's happening with their MS over time. And I think the biggest disconnect is people knowing that they are worsening in subtle ways, but they know it from their functional abilities, yet our assessments, whether they be clinical assessments or MRI assessments or other assessments, are not able to pick it up. And so we're entering into kind of a new area in a way in how we look at MS. Are we looking at MS as separate diseases or separate categories? Or as it was said earlier by Grace, that we're seeing MS on this continuum. But the continuum is moving towards progression. It's just happening in different ways, happening relative to relapses or non-relapses, meaning damage occurring in the central nervous system. So I think, too, the other comment I'd like to make is that I agree that there is a small difference here in terms of what benefit we may see. On the other hand, for someone living with secondary progressive MS, a small change could be absolutely profound in their life. And it could mean more functional ability for a longer period of time. When I look back at data we've collected in various patient advocacy organizations, we see that the number one thing that people are concerned with is progression. It's loss of function, the inability to participate in the things that they want to participate in. And so that unmet need is absolutely enormous. As we began with disease-modifying therapies back in 1993, there was about a 30% reduction in relative reduction in relapses. It would appear to me that we're in a similar situation at this point in time as we enter into trying to treat this subset in a way of progressive MS that's not having as active disease. So that's it. That's my only comments.
Well, Kathy, your comments were incredibly well appreciated. There's clearly an unmet need. I'm sorry, Lisa, I think we need to go on to our next presentation. Please excuse me. This time, and again, thanks for a very robust discussion. I know we could do this some more. At this time, I have the privilege of introducing Brett McQueen. Dr. McQueen is an associate professor, University of Colorado, and is going to give us the presentation on the evidence in economic modeling. Brett?
Yeah, thank you, Ralph. Next slide, please. So just want to acknowledge our team from Colorado, including Antal, and then from ICER, Marina and Marie, for all of their support. I'd like to disclose my financial support, not only from ICER, but I would like to report my compensation from Sanofi for a special speaker series at AMCP in April of 2024. It was related to type 1 diabetes, an area that I'm really passionate about and I've been working on for the last 10 to 15 years. But nothing related directly to a product or directly related to multiple sclerosis. Next slide, please. So our objective was to evaluate the lifetime cost effectiveness of tolobrutinib. Our comparator is best supportive care, and the population is non-relapsing secondary progressive MS. Next slide, please. So just had this conversation thanks to Kathleen about unmet need. And really what unmet need in this reference in terms of absolute and proportional equal value of life years gained shortfalls really means is there's some level of unresolved disease in terms of quality and quantity of life compared to the average age-matched American. But it really only makes sense when we look at other example conditions. So for example, chronic kidney disease or ALS. So you can see SPMS is quite burdensome in terms of its unmet need as defined by shortfalls of EVLY. Next slide. Next slide, please. All right, so our methods for this are pretty typical in terms of chronic disease cost effectiveness model. Our base case is going to be a healthcare sector perspective with a modified societal perspective in a scenario that I'll show you. In addition to our typical incremental and total life years gained, QALYs, EVLY outcomes, we include a clinical outcome of years able to walk without a wheelchair, which really makes sense when I start explaining the model structure. If we can move to the next slide. All right, so this model schematic doesn't necessarily describe everything that we're doing in the model. So I'll go through that now. But if you start on the far left-hand side, relative to the other states, EDSS1 has the fewest impacts on, for example, spending, quality of life, survival impacts. And then as you move to the right, and that discussion on nuanced changes in EDSS was really important, because that's really what we're trying to do at a very basic level in the model. Once you move to EDSS 6, 7, 8, and 9, you start seeing those costs increase for things like rehabilitation, durable medical equipment, impacts to survival, really significant mortality, and then also decrements to quality of life. In the base case, I'm going to get into this in a little bit, but we don't have anyone transitioning to and from EDSS 9. Again, I'll touch on that in a little bit. But in the sense that a treatment can impact this particular disease course, it's either delaying progression to the forward states, so that we're talking about the impacts on cost, quality of life, survival, not only delaying progression, but a treatment can also improve. So not only can you move forward, you can also move backward in the model. The other thing to note is that this is a simplification, because if we included all of the arrows, you wouldn't really be able to read the schematic. We can see patients jumping, from EDSS 4 to 6, or from EDSS 7 to 5. That is possible in this model, and I'll, at least I think you'll see that when it comes to the results. Next slide, please. So our model characteristics are reflective of the Hercules trial. Patients are on average about 50, majority female, and then right in the middle of that model schematic, the EDSS 5. So they're already starting pretty high up in that model figure. Next slide, please. There are a number of key assumptions. I urge you to read all of the assumptions in the evidence report. We'll note a few key ones that we think are important. In the base case, I mentioned this before, no patients transition to and from EDSS 9. We're using transitions through that model schematic from the Hercules trial. It's the best available contemporary evidence that we have on movement through EDSS states. The second assumption is the primary endpoint wasn't necessarily reflective of 1 unit increases in EDSS, and that's just how the endpoint was defined in the trial. It's not a direct mapping to that model figure that I showed you. 6-month confirmed disability improvement was another endpoint. We did not consider that in the base case. I'm going to show you what I call the most optimistic scenario where we include that. But at least in our conversations with clinical experts, there's a little bit of a question of, we need to see more data, more follow-up to see if this is really a true reversal of disease progression, in addition to the actual data on the treatment effects, where we saw improvements in very low proportions of patients for both arms of the model. Next slide, please. All right, so back to this sort of disease transition option. So what I'm talking about is movement through that model structure that I just showed you. The base case uses the most contemporary SPMS transitions. This is the very first review where we've used anything else but the London, Ontario cohort. It's also the first analysis that has used this data based on any other, for this population, in academic literature or anything. It's the only one that's used the most contemporary transitions for SPMS. So in that way, there's really a significant advancement in the field, thanks to Sanofi for submitting that directly to us. It also allows us to implement both progression as well as improvement treatment effects in both arms of, or excuse me, in the tolobrutinib arm of the model. So that was really important. We do see improvement in the placebo. I'm going to get to that in a little bit. So in reference to previous reviews, as well as the academic literature, I have a whole separate slide that I'm going to show you that uses the scenario analysis from the London, Ontario cohort, which started recruitment in about the mid to late 1990s. That does include all states from EDSS 1 to 9, but it only includes progression, not improvement. Next slide, please. All right, so these are some of the key inputs in terms of efficacy. This is really the base case, is the disability progression. So what that's doing, like I explained in the model schematic, we're delaying progression for tolobrutinib compared to placebo. So as patients are moving forward through the EDSS states, when we apply the treatment effect, there's this slowing of transitioning into those higher states, which cost more, decrements to quality of life, as well as increased mortality. In a scenario that I'll show you, the hazard ratio is actually flipped, because tolobrutinib is moving quicker for improvement. So we're moving backward at a faster pace than placebo. As you can see, both arms of the model, in terms of improvement, were less than 10% of the population. So it's kind of back to that third assumption that I gave you a few slides ago. Next slide, please. So we are using a placeholder price. It's based on comparative analysis from IPD Analytics. So as I walk through, I'm going to remind you that all of the results are using the placeholder price. The drug monitoring unit costs are really just reflective of anyone that's on a disease-modifying therapy with MS, so MRIs, provider visits, liver functioning tests. Next slide, please. All right, so this is where you're going to start seeing the model schematic match up with the inputs. At EDSS1, we still see quite burdensome in terms of spending, and anything associated with those lower states is still quite high compared to an average American. And then you see they really increased really dramatically for 6, 7, 8, and 9. Even though 9 is not included in the base case, I'm showing it here because we have it in the scenario analysis. So you can see that same trend of if a treatment's going to impact these spending estimates, you'll see it hopefully in the results, and you will when I get there. Next slide, please. So in order to calculate quality adjusted life years and equal value of life years, we use estimates of health-related quality of life that vary from 0 to 1, where 1 is perfect health. For EDSS1, you can already see the health-related quality of life impact. If you just take the average American, they start at about 0.85. So you can already see that there's a quality of life impact from MS. And then as you move further and further down, it's really substantial. And that shows up back to the unmet need estimates that I presented earlier, and then back to a treatment effect that can delay progression into those higher states. That's going to significantly impact quality of life. Next slide, please. Again, same trend we see with mortality. This is on top of or multiplicative of all-cause mortality. So we are modeling both all-cause mortality and then this excess mortality risk due to MS. Again, I'm showing EDSS 9 here. Even though it's not included in the base case, we do have it included in that scenario. Next slide, please. All right, so I'm not going to show you the modified societal perspective inputs, but they are available in the supplement. You can look at all of the estimates there. The indirect costs include the productivity losses, change in labor, employment participation, and informal care. They have the same trend. They range from these lower cost estimates to higher cost estimates each year or each cycle of the model. And then we also include the impact on a caregiver's quality of life. And that ranges from about no change to a maximum of minus 0.167. I urge you actually to look at the supplement because we have a whole set of how we actually characterize caregiver quality of life. We have separate scenarios that I'm not going to show you in the presentation just because of time limitations, but there's some interesting ways that we characterize this in the supplement. Next slide, please. Next slide. Let's see how this all shakes out in terms of the results. So the first thing to note is that we do have slight changes from the results in between the report posting and this presentation. That's going to be reflected in the final report. So anywhere that footnote is labeled, there has been a change, and you should see that change both in the presentation as well as the final report. Second thing, the far left-hand columns include the intervention-related costs for tolobrutinib at the placeholder price. So that's the duration of being on the therapy for a lifetime, plus those monitoring costs like MRI and liver functioning testing. Then that middle group, the non-intervention related costs, there's where we see the cost offsets. Those are the EDSS health state costs. So we're preventing or delaying progression into those states. That's where those cost offsets are showing up. So we do see an increase in the cost for tolobrutinib to the system of about $2.5 million versus about $680,000. In exchange for that, we see some health benefits, both across. Remember, I've mentioned this a few times already: quality of life, survival, disability progression. We're seeing that across all of our outcomes for quality adjusted life years, equal value of life years gained, and then again, years without a wheelchair into that EDSS 7 state. So we can see the benefit of tolobrutinib on health outcomes. Next slide, please. In terms of incremental discounted base case incremental results, we see a range of, at the placeholder price, tolobrutinib versus best supportive care being in this 1.5 to 7 million per outcome. So for cost per quality gained, 3.4 million, and for cost per EVLY gained, 2.9 million. Next slide, please. All right, so we ran a number of different input sensitivity analyses and then scenario analyses. I'm going to show you those now. Overwhelmingly, the most influential input, which is pretty consistent with other reviews that we do, is the efficacy parameter. And what we're doing here is taking that one input, using a confidence interval and saying, what if it was the lower or what if it was the upper, and then recording that result while holding every other input in the model totally fixed and not changing it. That ranged from 2 million upwards of 10 million per quality. So we're not meeting any commonly cited cost effectiveness thresholds. The other ones, while impactful, are hard to see in the scale of the figure, just given that the efficacy is overwhelming in terms of its impact. Next slide, please. So what if we varied essentially all of our inputs that have uncertainty? We use confidence intervals on multiple inputs in the model. We recalculate it 1,000 times and then take the proportion of those that met these different thresholds that are commonly cited in the United States. So that includes 50, 100, and 150,000 per quality, as well as equal value of life year. We see 0% of our simulations met those thresholds. Next slide, please. All right, so now we're going to get into some of these important scenario analyses. So the first one is the modified societal perspective. The second one is something that we saw in some of the early guidance around DMT use for MS. For example, a stopping rule in so many words, where once a patient reaches an EDSS score of 7, you would stop the DMT. And then finally, the third one is inclusion of disability improvement. So we're not only including the delay in progression, we're also including the increase in improvement for tolobrutinib as compared to best supportive care. That is the most optimistic scenario, and it dropped to about 1.3 and 1.1 million per quality and equal value of life year. All the other scenarios as well that we ran did not meet commonly cited cost effectiveness thresholds. Next slide, please. All right, so this is really the scenario analysis. It's very fascinating because it was a different era of care for SPMS. So the London, Ontario cohort, as I mentioned before, started recruiting in about the mid-1990s. We see that the incremental results essentially give us the same conclusion. They're right in between that 3.4 million and the 1.3 million that I just showed you. So we're just kind of right in the middle there in terms of the cost effectiveness results. But the interesting thing that maybe you don't notice right off the bat is all of the health outcomes are lower in absolute value compared to the base case. Again, this is a whole new era of treatment that really impacts both best supportive care as well as any DMT use. If you recall, the qualities, the EVLYs, life years, we were looking at about 6 to 7, and then for life years around 16, and then higher again for years without a wheelchair. These are much lower, and that just reflects not only just forward movement and disability progression, but it's just a different era of clinical care for SPMS. Next slide, please. All right, so when we take that 115,000 placeholder price, which has been throughout all of the results that I've shown you, it's all relative to that placeholder price. What if we drop it to meet those annual thresholds, annual price thresholds of 100 and 150,000 per quality and EVLY gained? Our range is around 3 to 6,000. There were some of the scenarios where we ended up in the range of 10 to 12,000, but still quite a bit lower than the 115,000 placeholder price that we're currently using. Next slide, please. All right, so we have a number of limitations. I mentioned some of these in the assumptions. So primary endpoints don't necessarily reflect 1 unit increments in EDSS. We have kind of some absence of data around the EDSS state 9. The scenario that I showed you with the London, Ontario cohort, you can see where that sat right in between the sort of base case and that optimistic scenario. And with any modeling analysis, there are a lot of data gaps, so long-term discontinuation, some of these sort of detailed costs across EDSS and other variability in the literature that we did our best to address in scenario analyses. Next slide, please. We received a number of comments from Sanofi, and really one of those was submitted in confidence, that transition probability matrix that I talked about. That allowed us to apply treatment effects for both progression and improvement. And it also led to the biggest change. If you're looking back at the draft evidence report and the current version of the report, that's what really changed. And so that's why we're focusing on that scenario that I showed you. There was also a comment that we received not only from Sanofi, but we also heard from clinical expert opinion. The model structure may not reflect these sort of nuanced changes in disability progression. We even heard one of our clinical experts say, hey, I mean, they could just have a bad day and it could be recorded as a different EDSS number than 3 months before or 6 months before. We completely recognize that. Modeling is always a simplification of a really nuanced and difficult reality that we can never truly model. So totally recognize that. Next slide, please. So to conclude, tolobrutinib for the treatment of SPMS is more effective through improving those outcomes that I showed you, quality of life, length of life, disability progression, when we compare it to best supportive care. When we use the placeholder price of $115,000 per year, tolobrutinib is expected to exceed commonly cited cost effectiveness thresholds in the US healthcare system. And I am out of time, and I believe I am taking questions at this point.
Thank you, Brett. Really a tremendous presentation. Really amazing. I already see a number of hands up from our panelists. Dr. Phillips.
Yes, thank you very much. That was great. Tell me more regarding the use of the wheelchair as the outcome measure.
Yeah.
Because we heard earlier that there was not enough data on quality of life. So I'm curious why you chose that.
Yeah.
And what are the implications of choosing that?
Yeah. No, it's a really good point. I mean, just operationally, when we say wheelchair at EDSS 7, that's really consistent with what the literature has published. It's not necessarily that we're saying, everyone in EDSS state and above is automatically in a wheelchair. That is how it's defined in the EDSS state sort of instrument. It is actually defined in a lot of ways on use of durable medical equipment, and we heard that earlier. But I would just think of it as the time to progression at that state of EDSS 7. And again, the reason why we showed it is really because a lot of the literature has used that as a metric. And then past ICER reviews have also used that. So it's kind of a reference point. I agree with you that sort of the way it's labeled might not necessarily totally represent exactly what we mean. It's just disability progression is really the way to characterize it.
Thanks. Jeffrey?
Thank you. Brett, congratulations to you and your team on a really complicated, complex model, looking at data and previous models, and great job. We're about to take a vote, I feel, today, and I felt like maybe your first bullet on your conclusions could be relevant to us. I believe you conclude that in the first bullet that the new drug is more effective. And I wondered if you meant that delta E was positive, or you meant that the confidence interval for delta E didn't include 0.
Yeah, really what I meant was that if we, over the lifetime, if we hypothetically applied tolobrutinib against best supportive care, we would generally at the mean level see gains across quality of life, quantity of life, and disability progression, just at the mean. When it comes to uncertainty, I think it's a really good point. That's why we showed all of those scenario analyses, right? Because we want to make sure uncertainty is part of your decision-making process, even though you're not going to take a specific value vote. But yeah, I would look at the scenario analyses in light of those clinical outcomes. And that's kind of also why I highlighted the scenario with the London, Ontario cohort, because the absolute values, they do matter. The clinical care is different and it showed up in the model. I think that's actually a really important point, that just best supportive care has gotten better. So also to answer your question, the delta, yes, at the mean level did improve in the tolobrutinib arm, but you also see that the era of clinical care has improved. And I think both are really key. So,
Lisa.
Yeah, thanks. We're talking a lot about qualities, and this will delve a little bit into our previous discussion with the clinical experts, but we've been hearing so much that the measurements depend on that day and so on. And I was really struck by Kathleen's comments that the patients know best. And given that, I'm wondering how well the quality of life assessments in MS are thought to be indicative of kind of the disease. Because to me, the patients are with the disease every day. So those quality of life assessments are going to reflect how they think they're progressing in the way Kathleen was talking about. So I don't know if the clinical experts have an idea of how well those correlate with example eventual progression, or Brent, if you do as well.
yeah, I mean, in terms of the clinical area, that's going to be out of my expertise. But what I can explain is there's a lot of variability in the evidence. So you could see one population filling out a quality of life score in defined in a state of EDSS 1 or 3 or 4 or 5, and then you could see a different population and a different result. So we actually ran, and again in that sort of supplement area, we ran a few different utility scenarios to make sure that we were capturing variability in the sample as well as variability in the evidence of an input parameter from our base case. So that just, I think, like my interpretation, which I would love a clinical expert to refute or confirm, is it seemed like there's two things going on. One, do they truly live in that EDSS state the way it's defined, right? And then second, is the quality of life instrument sensitive enough to capture the nuanced changes within that EDSS state? And I don't have an answer to that. That was the question going in my mind when reviewing the evidence.
And so just to be clear, it sounds like there isn't necessarily a great correlation between the quality of life and the EDSS. Is that right?
There's actually pretty good correlation, I would say, at the average level, but there's a lot of variability, I guess is the point. Like the mean estimates, you can see some overlap, but there's definitely uncertainty.
So Lisa, this is an important question. I'd like to have some more discussion on this. I don't know if our clinical experts or Kathy would like to chime in.
I'm happy to talk a little bit about it. Health-related quality of life, definitely on group level averages, moves in the direction you would expect. It's sometimes hard to deconstruct, the direction of relationships. And because people with MS, for example, are more likely to have comorbid depression and anxiety, those are sometimes included. It's constructs of quality of life, but also, of course, if you live with depression or anxiety, may influence your reporting as well. That also may be variable, right? Like, so from one visit to the next, we may see pretty marked differences, particularly in those depression and anxiety scores. I agree with Kathy that people with MS often do kind of get a sense that they're getting worse. I don't know that the quality of life metrics we have really reflect that construct, if that makes sense. Like, I do think that they can tell you, they'll say like, oh, I'm more tired. It's harder for me to walk, but I don't think that our quality of life scores, particularly ones that are traditionally included in phase 3 MS trials, necessarily reflect that.
Thanks, Ellen. Kathy? You're mute.
Sorry, I thought I had unmuted. My apologies. I agree with Ellen. And when you look at a group, you can kind of try and make some conclusions. The biggest problem in MS, to me, is that it's remarkably heterogeneous. And so we can have people with a very low EDSS have a terrible quality of life, depending on what's driving that or what their premorbid personality and response to illness might have been and their resilience level. And we can have people with an EDSS of 7.5 and 8 who think they have a very good quality of life. And any of us who have seen a number of people with MS can immediately coming to mind, these different people. So I think that it's always going to be challenging. And I do believe that when we measure, no matter what we're using to measure, when we measure, each individual is going to significantly impact whatever those outcomes happen to be. Time of day, what did they do yesterday? Have they been sick? All the things that Annette mentioned earlier are all going to impact our outcomes, which just makes this even more complex, right? And so I think quality of life is very, very tricky to measure. And it's most difficult to measure objectively with a form. It's never going to get it nuanced. So the best you're going to see, I think, from those kinds of measurements is group data, right? Which is what we're looking at in clinical trials anyway, is group data. So I think that when you look at those trends and the direction that it's moving, it does speak somewhat to what's happening at an individual level, but it'll never absolutely get to each person's disease or each person's quality of life.
Kathy, that's very insightful. I feel as a cardiologist, we're much more lucky in being able to assess quality of life issues than the complexity and the heterogeneity in MS. Jeff.
Yeah, so what I'm now, so as a comment, having taken care of MS patients for, 35 or more years, one of the issues is that if you rely too much on EDSS, you miss a lot of nuance on how your patient is doing, because the EDSS, is particularly in the higher numbers, is really dependent on your ability to walk. But that's only one component, right? So if you ask people why they can't walk, or why they can't work, for example, they're just too damn tired, and that doesn't necessarily get picked up in the EDSS. Or another huge impact can be continence, which may or may not be picked up depending on where your score is. And so you really need to look at the quality of life information as being sort of equally important. The big criticism, which is true for EDSS, is it's so dependent on ambulation that it misses a lot of important symptoms that people care about. And that's just something to realize. It's kind of intrinsic to the way the scale is.
Thanks, Jeff. Joy?
Thanks. Sort of a question and a comment, I guess, along this conversation on quality of life measurements versus the EDSS. So I think it's probably important to be a little careful when we use the words quality of life, because there's a sort of subjective sense that all of us have about what that means with our individual patients. But that's not the same as what gets incorporated into these models. And so I guess my question would be, what factors were incorporated into the quality measures used in the model? And were these MS specific quality of life measures, or were they the more generic ones that are typically used?
Brett?
Yeah, it's a good question, because kind of following up on Jeff's question, I was going to say a lot of what they do is they map and they record somebody's EDSS state, and then they use a generic instrument like the EQ5D to capture quality of life. That's how the link is made when you do the group average across EDSS. There aren't any, I mean, there are a lot of MS specific instruments. There aren't any that would translate to what we would call like a utility or a preference score. So most of that is driven through like an EQ5D generic instrument. But that's why I think it's important that there's the EDSS, and then there's this mapped on, and then there's, of course, PDDS, which I don't want to necessarily get into, but both of those are used as mapping to then get to a generic instrument.
Thanks, Brett. We have a couple more minutes. Annetta?
Yeah, so actually you answered my question. Thank you. So EQD5 obviously measures physical disability. It's a measure of physical disability. So it matters what quality of life or instrument we're talking about. We actually tested a bunch of them with our patients. The one they love the best, which is the most comprehensive, is still the MSQOL 54, but that is 54 questions. And it covers sexual function, cognition, fatigue. and they have those subscales. So the correlation, there is a mode or physical function subscale that corresponds very well with EDSS, but all the other stuff doesn't. And that is not used in clinical trials because it is long and the scoring is more complicated. So it's, purposely not just a simple Likert scale where you just add everything up at the end. And so, I'm afraid that even whatever instrument they did use in this trial, it's probably not the one that is going to more capture true quality of life in our patients most completely. And that's it. I want to hear what Nancy has to say.
Very fair comment, and I'm really interested in what Nancy has to offer at this point.
Well, don't get your hopes up too high. So a couple of just as a patient, my perspective on the conversation is that how you ask the question is everything. So if you are asking me if I am using my cane today, that is one question. If you are asking me how things have changed in the last 30, 60, 90 days, you will get a different answer depending on the day. And I think it's real important when these evaluations are being done that you put those kind of time limits in there, because some of the things that somebody else mentioned about, was it hot? Was it a long walk to the office? Did I teach a class online yesterday? Yes, I'm wiped out. Those are the things that will impact it. But if you ask me how I've done over a period of time, I can tell you. And I think at some point, everybody has bad days, but regardless of the diagnosis, at some point we have to trust the patient. At some point we have to take it with a grain of salt that the people in the trials are telling you based on how you ask the question to the best of their ability. And we just have to trust at some point.
Thank you so much, Nancy. And again, it really is a shame that we don't have the results of the MS Quality of Life 54 scale that I understand was actually collected in the study, but we don't have that. Jeff, you draw?
I didn't know how you were on time, Ralph.
For you, we have time.
Super, great. Well, I have a 2-hour question, which starts with a deck of 60 slide. Brett, can you argue that although you may not have the most perfect, totally exact right way with quality of life, you can argue that the model does seem to be affected by adjusting for quality of life? Because when you look at life years, you see a gain of about 3 months. When you look at life years adjusted for quality of life, you see a gain of about 6 months.
Yeah. So I think it's really important to take into account Nancy and Ellen's comments, which I've been following very closely, because what Ellen said, I think, is completely true. At the group average level, which is what we're doing and how population health decisions get made, you do see actually a really high correlation between EDSS and EQ5D. There's a couple of studies that have shown that. And EQ5D, just to sort of be clear, doesn't just measure mobility. It also measures anxiety and depression. And I think, as a lot of, maybe some of you know, EQ5D, there's a 3 level and a 5 level, which one is a lot more sensitive than the other. And that's been kind of reevaluated more recently. So yes, at the group level, we are seeing these changes. When we apply the treatment effect, we do see an impact on quality of life, and you should have seen the incremental difference. I'm not going to sit here and argue that it would work for every single patient, which I think is the discussion that a lot of the clinical folks are having, which is different than at a population level, right? So both are very relevant. Absolutely. We're not saying one is right or one is wrong, but in the model, we are at least seeing a trend, just as we see in these instruments when we actually put this in the model and model the treatment effect over time.
Thanks,
I don't
Brett.
know if that was an accurate argument, Jeff, but.
All right, this has been a great discussion. I actually would